So we have heard about the neo laser all day. Now we're going to get into the other product that Aerolase has, the Erbium YAG laser or ERA. So we go through the same thing, that application overview, laser mechanism of action, Aerolase protocols, clinical cases, and then discussion. This is me. My training is that I did a postdoc research fellowship looking at DNA of patients with pemphigus. Then did 3 years of internal medicine in Boston, 3 years of dermatology at UC Davis, then 2 years of laser fellowship at Mass General with Rox Anderson. And I'm in private practice in Massachusetts and New Hampshire. So there are different modes of laser resurfacing, non-ablative and ablative. Within non-ablative, there is spot treatments that could be used for dyschromia, spider veins, and active acne, as we learned about it. Then there are global treatments that can be used for rosacea, melasma, skin tightening, for pores, fine lines, etc. And ablative lasers can be used for deeper textural changes, deep lines, acne scars, and to remove individual lesions. So I'm going to go through how the lasers, ablative lasers have progressed through the history. So we started with CO2, went into erbium, and then went into fractional CO2 and erbium, and now we have this 300 microseconds full field erbium laser from Aerolase. So this is what essentially we want to do. Nature did this to us, and we want to reverse and make it look like this. See if we can do that. So all the treatments that are used for anti-aging purposes, lasers in terms of light, energy-based devices, CO2, erbium, a variety of non-ablative lasers, and then radio frequency devices. So CO2 laser, we know the wavelength is 10,600. Chromophore is water. It causes ablation and coagulation. It can be used as pulsed, a flash scanning device. Can be used with a focused or collimated beam. You can use a CPG scanner or a freehand. The first lasers were freehand, and then we got the scanners, so it became a lot easier to do that. And you get excellent results, but this is the problem, is the downtime. This is to show where the absorption curve is. Here's water, here's 1064. So here's the water absorption for CO2. This is the peak for erbium. So first we used the CW, or continuous wave CO2 laser, which was used for surgical purposes, for excision and to remove hemorrhoids, as we learned in the morning. Also for tattoo removals. The skin temperature could go up as high as 200 degrees Celsius. There were up to 1 millimeter thermal necrosis, the char formation, and ultimately led to scarring. So almost always when you use continuous wave CO2 laser, it will give you a scar. So we developed these pulsed CO2 lasers, and if you keep the pulse duration less than the thermal relaxation time, which is described as the time required to lose 50% of the heat once you deposit into it. And the TRT for the upper skin was 1 millisecond. So if you keep the pulse duration less than 1 millisecond, you can avoid peripheral damage with that. So the first paper was published by Dr. Wieland and his colleagues. The super pulse lasers minimizing the thermal damage with short pulse duration and high irradiance pulses was as early as 1987. Rox Anderson and Jay Walsh published this paper in a guinea pig skin study that if you use 50 millisecond pulse, you get 750 microns of thermal damage. If you use 2 microseconds, you get only 50 microns. Published in a year after the first study. Then in 1989, Larry David and Gary Lask, they published this paper. Actually, Dr. David was the first one who used any ablative laser for cosmetic purposes in California. And what they found is the laser ablation for cosmetic and medical treatment of facial actinic damage in 1989. Then Dr. Fitzpatrick, who's considered the father of this ablative resurfacing, he published several papers. One of them was the single exposure human skin study with continuous wave and superpulse CO2, with continuous wave 200 microns of damage, with superpulse only 100 microns. So how does it really work, this ablative resurfacing? Well, we'll remove the epidermis completely. We're talking about full ablative resurfacing here, and part of the superficial dermis. And it leaves this thermal damage behind, and then there's a formation of new epidermis and new collagen, which makes the skin tighter, and makes the wrinkles better and scars better. The dermal collagen is mostly type 1 with denatures at 60 to 70 degrees Celsius. There's collagen shrinkage with CO2 laser. If you have seen full ablative CO2 resurfacing, there's an immediate contraction of the skin that you visually see it. And then there were studies done at that time to figure out whether this immediate contraction is the cause of the final results or the later contraction that results in neocollagenesis, which leads to that. And the new collagen is that's found is also type 1. And Victor Ross and Rox Anderson published a wonderful paper several years ago, why does CO2 resurfacing work? And what they found is that there are 3 zones that we leave behind. And the first one is 60 to 100 microns. This is the residual thermal damage. Then 1 to 20 micron, and 30 to 250 microns. The important thing is the depth of treatment, not the depth of ablation. What is the depth of treatment is the combination of ablation and coagulation for CO2, which is dependent upon the fluence we use, the spot size we use, the pulse duration we use, number of passes we use, and also repetition rate. I was at a conference in Italy. It was a plastic surgery conference, and one of the plastic surgeons, he presented a case, and he said this doctor in Pakistan treated this patient with CO2 pulse laser, and the fluence was very low, the spot size was fine, but the patient ended up with scarring. And I asked him what was the repetition rate they were using. He said 10. Now 10 is so fast, and if you're not moving your hand fast enough, you're going to stack the pulses, over-treat it, and end up with the scars. Daniela Duke published a paper on shorter pulse CO2 laser 1998 with 100 micron seconds versus 1 millisecond. This is what the problem was with CO2 laser. This is hyperpigmentation and line of demarcation. This is my earlier patient. Same thing with this patient. It's also my patient. She had a facelift done, which she ignored to tell me. And then when you do the facelift, they kind of pull the skin up. This is the neck skin, which always reacts differently with resurfacing than the facial skin. So she ended up with hypopigmentation. So we thought that maybe we should find something else that works better than CO2 laser, and less downtime and less complication. So we started working with this 2.94 wavelength Erbium YAG laser, same chromophore water. At that time, the pulse duration was 250 microns, and we get excellent ablation, very little coagulation. Same thing, you could do a freehand treatment or use a scanner. You could get excellent results with that too, but the issue with that was bleeding, and I'll tell you why. Here is the absorption of erbium in water, and here's CO2. So it's 10 times more efficient absorption in water with erbium than with CO2. If you wash the treatment with both lasers, there's a popping sound that you hear with erbium, and there's a lot of more smoke with erbium than with CO2 because the absorption is so effective that it pops. So you not only get the ablation, but you also get photothermal effect from that too. And that's why, because there's no coagulation, so there's always a bleeding issue. If you're treating a patient for photoaging and the patient also has rosacea, after 1 or 2 passes, the patient will start bleeding. And think about it, or chromophore is water. So if the blood is on the skin surface and you hit with the erbium, most energy is going to go into the blood and less is going to go into the skin. And the treatment won't be as effective. There's a trick to do that, but that's the issue with that. So this was the first study that was published in a side-to-side comparison. We treated one side with erbium and one side with CO2 laser. We did it with Rox Anderson at Mass General in 1999. It was published. And what we found is that the residual thermal damage with CO2 was 200 microns versus only 50 microns. These were the histologies we did. And the fibroplasia, new collagen formation, was 200 micron with CO2 and 475 micron with erbium. And what the final results were that you get excellent results with 5 passes of erbium and 3 passes of CO2. So you have to do a little bit more number of passes, more aggressive treatment compared to CO2. Why? I'll explain that to you. This is just show what the side effect profile was, that we got more erythema, more edema, about the same hyperpigmentation, but this is where the main difference was. 43% of those patients showed hypopigmentation, which usually is permanent, versus only 5%. None of them got any scars or infection. This is just to show the same information. This is where the residual thermal damage is. After 3 passes of CO2, 5 passes of erbium. You can see there's only a thin rim of this coagulated tissue, which is maybe about 20 microns. And this is over 200 microns, you can see right from there to there. This is the most important slide. This is from Dr. David Goldberg's book. This is the depth of ablation versus the depth of treatment. So when you do the CO2 treatment, this is, you ablate this much tissue, and you're ablating same amount of tissue with CO2, but you're leaving this carbonized tissue behind, which is going to slough off in the next few days. So your depth of treatment is here, versus with erbium, it's superficial. So if you do the same number of passes, you're not going to get the same kind of results. You have to go deeper than that and bring your depth of treatment to the same level to get to the same kind of results. That's why I took 5 passes of erbium versus 3 passes of CO2 to get the same results. The couple patients from that study, this is the CO2 side before, a month after, 6 months after. You can see this hypopigmentation here. Same kind of results without hypopigmentation. This side was treated with erbium and this with CO2. This was 8 passes. You can see because she has such deeper wrinkles. And you can see the results are at least the same as CO2, if not better than CO2. Bob Adrian published his paper in 1998 saying that the CO2 can give you better results than erbium. And then a few years ago, Christopher Zachary, he published a paper saying the same kind of thing. And I wrote a letter to the editor proving and showing these photos that you can get the same kind of results with both lasers. The results are not wavelength dependent. They are depth dependent. Depending upon the depth of your treatment, you can get the same results. It doesn't matter which wavelength you're using. Except that with CO2, you get more complications, more downtime compared to erbium. Then the people try to simulate more like CO2 erbium lasers or longer pulse duration to decrease bleeding, increase coagulation, increase RTD, single erbium YAG laser, 2 different erbium YAG lasers, short pulse, long pulse. Tried everything to see if you can get better results with that. And some people were combining both lasers. Some were doing CO2 first, erbium later, or erbium first, CO2 later. And then it wasn't really as popular procedure because of the downtime. And then people tried to do single pass CO2 and then non-ablative erbium lasers as well. Nothing was really that effective. This is skin type 5 that I did a full face, full ablative erbium resurfacing immediately after, a week after, a month after, and 6 months after. Hyperpigmentation from full ablative resurfacing, hypopigmented, scars, herpes. This is not my patient, it's a photo from Dr. Jeff Dover's book, Severe Scarring After CO2. When people started using CO2 laser early on, about 20 years ago, they didn't know what the parameters and all that. There was no scanners, it was freehand, and there were a lot of complications. We saw several of these patients, they came to Mass General to get the treatment for scars. Another patient, wow. You can see that he has all kinds of scars. There's an hypertrophic scar and all that. So then people started getting into using non-ablative lasers, and any laser you name it was used for this. But the problem was, if you look at before and after photos, you never know which one is before and which one is after. So that went out the window. So then we started to see, well, what's the other options? And still remember Dieter Menstein and Rox Anderson and Gregory L. Shooter at Palomar Laser Company in Burlington, Massachusetts. They are in the meeting, and they asked me to come to this meeting, and they said, we have this concept here to using this laser just to treat the fraction of the skin rather than the entire surface of the skin. And I became part of that study that showed here that you can get these thermal, altered microthermal zones, which help the skin look tighter. Here are those channels. This is what became Fraxel later. But we're still not getting the same results what we were getting with the full ablative CO2 or Erbium laser. So we thought, well, how about we combine two technologies together? So how about we do fractional ablation of the skin, and then fractional ablative lasers came into play. This is just a cartoon to show this is non-ablative treatment, full ablative. Fractional ablative, you can go as deep as you want depending upon the energy you're using and the number of passes. And this is 1540 or 1550 Fraxel laser, just these non-ablative channels. A couple of my patients with Erbium, acne scars, skin tightening. This lady here, she only wanted her perioral area treated. This is 2 months after. Then she didn't come back after the follow-up. But if you look at this area here that was not treated, also got better because there's so much tightening here that it pulls down that it got better with that too. Now there are also home use lasers for hair removal, skin rejuvenation, skin tightening and all that. And nothing is as close to as what we do in our offices. This is the evolution of from CO2 to Erbium and now to 300 microsecond full field. What we can focus here is that you can get the profound results with a single treatment like other ones. There's no need of topical anesthesia in most cases. Downtime is very little, 3 to 7 days, depending upon the energy, and virtually no pain, and there's no bleeding with that. What are the parameters? We know it's a very efficient absorption in water. There's lack of collateral thermal damage because of the 300 micron pulse duration, and you can go as fast as 1.5 hertz. And that also helps to decrease the thermal buildup. This is again to show the absorption curve. This is the Erbium, that's the CO2. Same thing here, ablative laser histology to show the thermal damage, how much thermal damage is left behind with different parameters and different wavelengths. What is the advantage of 300 micron Erbium? You avoid collateral thermal damage. You get profound results with a single treatment with less discomfort or downtime and the risk of complications. You can ability to modulate ablation depth with each cosmetic zone treatment tailored to each patient, and there's no line of demarcation. One of the issues is one of the issues with the Erbium and CO2 ablative or fractional ablative laser is that if you treat a small area, they're going to look different than the rest of the face, especially if a person has any lentiginous or actinic bronzing on the face. But the advantage of this technology is that you can treat small areas as well without treating the whole face. Obviously, it's much better to do the whole face, but there's no reason not to treat like just the perioral area, just periorbital area. And this is just to show the different zones can be treated at different times. This is graphic way to show in terms of downtime. This is just a little couple days, fractional ablative, several treatments and long downtime. And the longest downtime is the full CO2 laser, could be 2 to 4 weeks at least. So we have 3 different ways to use this erbium laser: refresh, reveal, and renew, depending upon how aggressive you want to be and what the patient's needs are. Refresh is subablative treatment to create a smooth, uniform shine and refresh the skin. Reveal, we'll talk more detail about each one of them, is partial epidermal ablation, what's called micropeel, which removes sun-damaged skin, larger pores, and finer wrinkles to reveal a youthful skin. Renew is the most aggressive. It's still gentle resurfacing for deeper lines, acne scars to renew the epidermal skin tissue. How we do refresh is for skin type 1 through 4. 10 millimeter lens, energy mode is 1. 1 hertz is the rep rate. Lens is held about 3 inches away from the skin, and it is used in a subablative mode. You can treat the whole area. Number of passes per session are 3 or more. A number of treatments 3 or more. Treatment interval 3 to 4 weeks. That the number of treatment and number of passes all depends upon what the patient's need is. I have a patient, she knows I have so many different lasers, but she always comes back and get this treatment done. And she'll call me 3 months, and she moved back to Brazil, came back, and she said, I just want that treatment because it doesn't hurt, it's quick, and I get the results what I want. She's not old, she's only 29 years old, but she loves those results. Here's a case. Reveal, again, is skin type 1 through 4. You could use 6 millimeter lens, and the energy mode is 1.5 hertz. You do global treatment, number of passes per session 1 to 2, number of treatments 1 to 2, treatment interval 4 to 6 weeks. Again, depending upon the patient's need, it could be more number of treatments or less number of treatments, more number of passes or less number of passes. Here's a case. Renew for skin type 1 to 3, 6 millimeter lens and 10 millimeter lens, energy mode 1, 1.5 hertz. This combines deeper spot ablation with the reveal treatment. Number of passes per session as needed. Number of treatments usually is 1. And again, once the patient, all the healing is done, a few weeks, couple months afterwards, if needed, another treatment can be done. You can appreciate the improvement in these lines here. Remember, there's only a few days of downtime, no pain involved, no bleeding involved. A few cases. This is a micro peel. It's after 1 treatment. Resurfacing after 1 treatment. Dr. James Gordon's patient. His patient again after blepharoplasty. So combination of treatment, as we talked about in the morning too, combination of treatment is the key. You don't have to stay with just one device or one procedure. You can always combine these. I used to work with an oculoplastic surgeon, and he used to do blepharoplasty and immediately after I was doing the resurfacing, and we got great results with that. 3 days and 5 days, you can see how fast the recovery is and also the results. Dr. Gordon's patient. Here's a deep resurfacing after second treatment. I don't know how long after the second treatment this photo is taken, but it looks like probably a few weeks after. Deep lines. Dr. Gupta's patient, she's here. I'm sure she'll discuss this. Acne scars after 2 treatments. Perioral wrinkles, just 1 treatment. It's a combination of Neo and Era. So you do first three passes with the light path Neo for collagen remodeling, and 4th pass was just 20 micron skin resurfacing with the Aerolase. And this is after second treatment. Dr. Friedman's patient. So burn scar treated with Era after 2 treatments. This is one of my patients. What we did we did a few patients immediately after excision. We treated half the scar with Erbium, right after we put the sutures in. And this is 6 months after. You can see the half that was treated with Era, much better scar than the half that was not treated. My last before and after patient. There's before. There's after. Oh, this is Dr. Bloom's patient. Is this surgical scar revision before and after? This was Aerolase, 300 microsecond, 5 joules per centimeter square. 1 to 2 passes, 1 to 12 passes, sorry, and number of treatments for 2. And you can see how much improvement you see with the scar. So not only Neo can be used for scars, this can be used as well.